On to the next presentation that will be on diabetes mellitus and cardiovascular risk.
Thank you.
Looking beyond the glucocentric approach, Dr. Peyush Khera, Senior Consultant Cardiologist from Lucknow, is speaking for 12 minutes followed by 3 minutes of discussion. Dr. Khera, please.
Good morning, everybody. With the permission of Chair, I must thank the organizers for giving me an opportunity to speak in front of such an august gathering. Now today I have to speak on diabetes mellitus and cardiovascular risk, looking beyond the glucocentric approach. At the very outset, I must confess that I am not a diabetologist, but as Dr. Eugene Braunwald has said, surely the time has come for cardiologists to learn more about diabetes and for diabetologists to learn more about cardiology. Perhaps it is now appropriate to establish a new specialty, diabetocardiology, whose practitioners become the frontline troops in this war. So the diabetes and coronary artery disease have a common background. Type 2 diabetes is the most common form of diabetes and is a major risk factor for coronary heart disease. Now, as reported by the International Diabetes Federation, around 537 million people worldwide have diabetes, and by 2045 it is predicted that around 700 people will have diabetes. Whereas the microvascular complications contribute to morbidity of type 2 diabetes, it is the macrovascular complications which lead to morbid mortality. That is coronary artery disease and stroke. And screening of people with type 2 diabetes for cardiovascular risk is an important strategy for reducing mortality and cardiovascular disease events. So the burden of coronary artery disease in type 2 diabetes is also very important. And in a systematic review in 2018, around 45 lakh patients were studied, and the overall prevalence of cardiovascular disease was estimated to be around 32.2%. The most frequent type of cardiovascular disease that was reported was coronary heart disease, around 21.2%, and the least frequent of stroke, around 7.6%. And the prevalence of myocardial infarction was 10%, and the prevalence of congestive heart failure was around 14.9%. So the risk of coronary heart disease in patients with type 2 diabetes, there's a 2 to 4-fold increased risk of coronary heart disease in patients with type 2 diabetes as compared to patients who are without diabetics. And although the overall risk of coronary heart disease is lower in women than in men, the relative risk of coronary disease in women with diabetes is compared to those without diabetes around 40 to 50% higher than the relative risk among men. So we need to carefully tackle females also. Now, what is diabetes and coronary artery disease? They are not just risk factors. There's a complex relationship that exists between the metabolic milieu associated with diabetes and development of atherosclerotic cardiovascular disease. In particular, the development of renal impairment markedly increases the CV risk, and there's an increasing awareness that unrecognized heart failure is accentuated by the presence of both renal and cardiovascular disease, further increasing morbidity and mortality. And the insulin resistance syndrome is also a CV risk factor. You can see that the inflammatory markers lead to insulin resistance, which in turn leads to hypertension, hyperglycemia, dyslipidemia, and these in turn lead to an alteration in the coagulation cascade and then lead to subsequent atherosclerosis. Now, what about the glucocentric approach? Is the current glucocentric approach for the management of type 2 diabetes misguided? So there were a series of therapeutic letter initiatives right from 1994 to 2016. And what they have pointed out in the last is that the researchers conclude that the glucocentric approach to the management of type 2 diabetes is probably not in the best interest of the patients. And what I have highlighted here is that the various letters have shown that there is no conclusive evidence that improved glucose control with oral agents lead to a decrease in the complications. Metformin added to maximal sulfonylurea therapy was harmful. Most non-insulin patients of diabetes do not require SMBG. There is limitation and potential hazards of using surrogates like HbA1c, and the use of non-insulin lowering drugs and this marker of HbA1c for basis of their approval is basically not recommended. The other analysis of the current evidence in 2009, the endocrinologist from the Mayo Clinic suggested that tight glycemic control burdens patients with complex treatment programs, hypoglycemia, weight gain, and costs, and offer uncertain benefits in return. In 2011, when intensive glucose lowering was compared with standard care, the magnitude of harms outweighed the risks. And again in 2011, leading diabetic experts argued in the British Medical Journal that our obsession with HbA1c as a surrogate is damaging patient care. A systematic review in 2016 of metformin documenting the cardiovascular and mortality benefit of metformin seen in one arm of the UK PDS was contraindicated in the other arm of the same trial, and not seen in any other RCT and has never been replicated. So they have reviewed practice guidelines from 2006 to 2015, comparing them with the meta-analyses and individualized RCTs. The evidence accrued in the past 2 decades consistently demonstrate no significant benefit of tight glycemic control on patients' important micro and macrovascular outcome. So the current evidence strongly support that there is a potential epidemic of over-treatment of anti-hyperglycemic drugs in diabetes. So what is needed now? At the present time, we do not have proof for the glucocentric approach for any drug related to diabetes. And while we await the trial evidence, it is rational to emphasize lifestyle measures in these patients, weight loss and low carbohydrate diets. Then came the concept of the cardio-renal risk reduction approach, and this concept has been put forward by Stephen Jacob and colleagues and published in 24th July 2021. And for many years we know that the lowering of glucose by the use of various drugs have not led to the reduction in macrovascular complications. In the past few years, certain drugs like SGLT2 inhibitors and GLP-1 analogs, which we presently developed for glucose lowering, have shown that the reduction in macrovascular and renal complications do occur. So these studies have prompted a debate into what is the main aim of treatment of management of type 2 diabetes. So this has led to the evolution in the approach to the management of diabetes. The initial, according to the consensus of ADA and ESD, the initial targets in 2009 were the HbA1c reduction, and the strategy was the lower the better. But this approach was based on the UK PDS trial, whereby the legacy effect and the UK PDS follow-up was also very controversial. And also the initial concept of MACE was not there. So subsequent to the 2009 guidelines, the trials of the ACCORD, ADVANCE and VADT were presented, and the studies concluded that strict control of diabetes by polypharmacy reduces HbA1c but even it causes an increase in the mortality. And this was what they attributed was due to hypoglycemia and weight gain. So in 2015, the ADA and the ESD recommended the therapy target should be HbA1c. The strategy should be the lower the better, but to avoid weight gain and hypoglycemia. But subsequently, because of the availability of the various cardiovascular outcome trials with the SGLT2 inhibitors and the GLP-1 receptor analogs, the therapeutic target has shifted from HbA1c lowering to cardiorenal events. And therefore, the strategy is blood pressure lowering, lipid lowering, and glucose lowering by drugs which have proven safety and efficacy. So era-wise, anti-diabetic agents have also been changed. You can see that by the first era, whereby reducing the HbA1c was important, it was the sulfonylureas and the insulin which were in vogue. In the second era, when we wanted the reduction in HbA1c but without hypoglycemia and weight gain, we had a plethora of drugs like biguanides, acarbose, and DPP4 inhibitors. In the third era, the lowering of the cardiovascular and renal risk is there, and thereby the approach has pointed out in favor of SGLT2 inhibitors and GLP-1 receptor agonists. There could well be a dawn of the new era in the management of diabetes. It is stated that with the advent of the SGLT2 inhibitors working and causing morbidity and mortality benefit even in non-diabetic population, then this fourth era would be there, which these agents are used extensively for cardiovascular and renal protection regardless of the presence or absence of diabetes. So the recommendations from the guidelines have stated that the SGLT2 inhibitors and the GLP-1 receptor agonists have been recommended in patients with type 2 diabetes and existing cardiovascular disease in all major and international guidelines. The recent European Society guidelines have gone a step further and recommended that these agents should be as a first line, replacing metformin in drug-naive patients with cardiovascular disease and diabetes. So this is the treatment algorithm. Patients who are having ASCVD, either if they are drug-naive, in these patients it's recommended that an SGLT2 or a GLP-1 with proven CV benefit is the first line because of the major CV benefit derived from the CVOTs described in the text. And if glycemic control is inadequate, then it is recommended under these circumstances to add metformin as a second line. And in patients with CVD who are already on metformin, this metformin should be continued, but then SGLT2 inhibitors or GLP-1 receptor agonists should be added to the treatment protocol. So the mechanism of action of SGLT2 inhibitors also needs to be considered, and what our teachers have taught us that if there is a plethora of data regarding the mechanism of action, then probably we don't have the answers. So we have a variety of vascular and hemodynamic effects, renal effects, cardiac effects and metabolic effects of SGLT2 inhibitors, leading to their beneficial effect in the cardiovascular morbidity and mortality. There are certain anti-atherosclerotic effects of SGLT2 inhibitors also seen by reduction of dyslipidemia, reduction of endothelial dysfunction, reduction of inflammation, inhibition of leukocyte adhesion, inhibition of foam cell formation, reduction of plaque burden and increasing plaque stability. So the current evidence supports the use of SGLT2 inhibitors. They can reduce the risk of MI, but the risk of unstable angina, transient ischemic attack, arterial revascularization, peripheral arterial disease, they seem to be unaffected by SGLT2 inhibitors. A meta-analysis of the randomized controlled trials in patients with diabetes suggests that empagliflozin is associated with a reduced risk of cardiovascular death and MACE. Canagliflozin is associated with a reduced risk of MACE, while all other analyzed SGLT2 inhibitors, including EMPA, CANA, DAPA, and ER2, are associated with a reduced risk of heart failure hospitalization. A word about GLP-1 receptor agonists. The GLP-1 receptor agonists are administered by subcutaneous injection except for the oral semaglutide, which is recently available in our country. The GLP-1 receptor agonists have been associated with the reduction of major cardiovascular events and mortality on the basis of the results of the CV outcome trials. And there have been around 7 trials with a total of around 56,000 patients with various molecules like lixisenatide, liraglutide, semaglutide, exenatide, ebliglutide, dulaglutide, and the oral semaglutide. Now coming on to the meta-analysis of the GLP-1 receptor agonist trial, they have shown that they have reduced 3-component MACE and each component as well as all-cause mortality, but has no effect on the hospitalization for heart failure. Also, treatment with GLP-1 receptor agonists have reduced the risk of worsening kidney function, mainly due to decrease in development of macroalbuminuria. So if we compare GLP-1 receptor agonists and SGLT2 inhibitors, we find that GLP-1 receptor agonists mostly decrease ASCVD, whereas the SGLT2 mostly decrease heart failure. The GLP-1 receptor agonists decrease in albuminuria, whereas the SGLT2 inhibitors decrease chronic kidney disease and albuminuria. To conclude, for the anti-diabetic drugs, the GLP-1 receptor agonists and the SGLT2 inhibitors provide cardiovascular and renal benefits in people with type 2 diabetes and high cardiovascular risk, adding further reduction in MACE, morbidity, and even mortality to standard cardioprotective medications such as antihypertensive agents, antiplatelet aggregating inhibitors, and lipid-lowering agents. And the benefits seem predominantly independent of intensive glycemic control. But a point of view has come up that both glucocentric and cardiocentric approach are necessary for a resilient disease like diabetes, and they have pointed out that caregivers must follow a dialectical thinking to choose a synthesis approach whereby the glucocentric approach is as important as control of cardiovascular risk factor and should remain a target to be achieved. I've just got a single slide which shows that the targets of HbA1c have been relaxed. Hypoglycemia has to be avoided at all costs. Use of GLP-1 and SGLT2 inhibitors are increasing. The LDL targets are going down. The secondary lipid targets are also becoming more stringent. Smoking cessation has to be maintained. Blood pressure is being relaxed.
Can you conclude the slide?
Yes, it's just the next slide is concluding. Diabetes mellitus is a chronic metabolic condition characterized by the presence of fasting hyperglycemia and development of micro and macrovascular complications. The macrovascular disease is a complex phenotype that is best managed by dealing with clustering of risks. Recent outcome trials have provided important evidence to support the use of aspirin, novel anticoagulants, and new class of diabetic treatment in prevention of CV disease. The current guidelines recommend the use of SGLT2 inhibitors or GLP-1 receptor agonists with proven CV benefits independent of baseline HbA1c to reduce the CV risk in type 2 diabetes. Despite major advances in outcome, patients with diabetes continue to show residual risk in comparison to patients with non-diabetes treated in the same way. The cause of residual risk has not been characterized. Thank you very much.
Thank you. We just have one possible comment, Mr. Chairman. That's the only time that we have.
Any questions from audience? If no question, may I ask you a question? Dr. Bhardwaj will ask.
To know that recently SGLT2 inhibitors, they start talking that they are going to help these patients, particularly patients of CAD, hypertension with heart failure. They are recommending that SGLT2 inhibitors can help these patients. By increasing the diuresis, they decrease the load, water load and salt load on the heart. What do you say about this SGL2 inhibitors?
So
Should they be used as one agent in these patients, particularly in setting of heart patients, old MI, coronary artery disease? What do you say?
So, as pointed out earlier also, that the use of SGLT2 inhibitors in heart failure is the class 1 indication. It is a pillar of heart failure therapy. So in patients of heart failure, the SGLT2 inhibitors have got now a class 1 recommendation, even if the patient is non-diabetic. If the patient is diabetic, then we have other indications for ASCVD, for coronary artery disease, for heart failure, all associated with diabetes. You can have SGLT2 inhibitors, and even for glucose lowering, they have found out that the SGLT2 inhibitors and GLP-1 receptor agonists are to be used as the first line.
That's the only time that we have, Mr. Chairman. We'll have to move on to the next presentation. Thank you. I'm extremely sorry. Please take it up with the speaker in person. We are scheduled behind time. Thank you, Dr. Khera.
CVS